Hey, what's up, everybody? Thank you so much for coming to my channel. I am super excited because I have great news. I wrote a book, okay? My book is called 12 Case Studies. So please be sure to get your copy. Today, just simply look below for the information on how to access the ebook as well as the paperback. All right, guys? So enjoy the video. Hey, what's up, everybody? So it is a beautiful day today, and I decided to do a quick vlog for you guys to answer part 2 of the Q&A. Check out the first one. The first Q&A I had was a question about practice model, and I'm going to give you part 2 of that, which was what is my therapeutic use of self when I'm dealing with difficult patients, and the other question was what are the common diseases that I often see. So for those of you that do not know, I work primarily in skilled nursing facility. I have worked with pediatrics, but my go-to is SNF. Now, the common diseases I often see is pretty broad, but I would say for the most part I see a lot of congestive heart failure, dementia patients, lymphedema, COPD, stroke. I've had a couple of paraplegics. Honestly, the list really goes on and on. A lot of UTI cases. I'm just speaking on the top of my head right now, but there's quite a few physical disabilities. Let me just say it like that. I see quite a few physical disabilities. Now, since I work with the more of the senior population, that's what you're getting. Occasionally I'll have a few TBIs, but for the most part it's, maybe an open heart surgery patients, which we call cabbage. And the thing is some of these diagnoses that we get are paired and coupled with other impairments. So should just say that somebody comes in with one diagnosis is not fully true, because they may have a primary diagnosis, but they have other underlying impairments that either leads to that or makes it a lot harder for them to improve because of. I also deal with a lot of cognitive impairments, also visually impaired. So I have a couple of patients that, they can't see. So we go through a lot of adaptation techniques, compensatory techniques, to kind of help somebody who is blind or who may be a recent blind person how to navigate. Now, usually people that tend to be recently blind, they actually go to specialized training for that. So most of the people that we get may have had an injury, they're out of their element, or just having difficulty with basic ADLs. So there's kind of cues and tactile feedback and training like that I work on. Now, to answer your question on how I use therapeutic use of self. So I decided that I'm going to use, if you can see there, whoops, there's a fly. Sorry guys, I'm outside of my house and there's a fly flying around me and it just won't leave me alone. Okay. Seriously, fly? Really? You want to be in the video? So I'm going to use what I have put in my book to answer your question, because if you get my book, this actually answers that question. Therapeutic use of self when you deal with difficult patients. This book is meant for skilled nursing facility patients. However, part of the question is, what would I do if I had a child that just wanted their mom and they were being difficult? First, you got to analyze the situation. You got to see what the child really wants from the mom. If it's more of a separation anxiety, you have to, what I would do, in my opinion, you would ease the child away from the mother. So for example, let's say on day 1 of therapy, I would see how the child responds. If the child is completely clingy, doesn't want to leave mom's side, to attach to mom's leg, I will incorporate mom in the first initial treatment. In the first initial treatment, I will have mom slowly start backing away from the child. By the end of the treatment session, I'll probably have mom on the other side of the room while I'm working with the child as well. Okay? That's way of doing it. Then the next treatment, mom is, again, on the other side of the room to initially start with. It may take maybe 2 or 3 sessions to get mom to be at the side of the room and away from the session. By the third session, I'll probably have mom maybe behind the door, staying by or something like that, seeing how the child handle it. Usually, when children become difficult and they're crying for their mom, it's because of the parent tends to be your protector. So a child without their parent may feel a little vulnerable, so you have to allow that child to feel comfortable knowing that they're safe. It's more of a safety response. So ensuring the child and the mother as well, because moms tend to want to hold on too. So incorporating the mother, allowing the mother to also feel comfortable, that's also going to allow the mother to, allow the child to back away and, respond to you. And also having the mom come in periodically can help. I suggest not to do that in the beginning because then you may be starting over. So I hope that answers that question about dealing with pediatrics. Again, pediatrics is not my primary focus, but I have worked with children, and that's what I've done in the past. So back to therapeutic use of self. So if you pick up my book, this also speaks about, in my book, in my table of contents, I actually give you a lot of the diagnoses I've seen, and I've listed about 12 of them. And if you look in my book on the last chapter, page 97, I'll show that to you. Okay, page 97. It tells you how to motivate the unmotivated. That's what I called it, the unmotivated. So I'm just gonna go to page number 97 in the book, and I'm just gonna read to you guys. I hope you don't mind. All right. Maybe I won't read. I'll probably break it down because it might be a lot to read. So the first thing I said is how to motivate the unmotivated. There are factors that must be addressed to find out the underlying cause of poor motivation, lack of interest, failure to thrive, being uncooperative, detached, and all the other terms we therapists use to describe a patient unwilling to participate in therapy. Okay, by analyzing these 3 comprised areas. 1 is emotional health, 2 external factors, and 3 is misunderstood rehabilitation expectation. These are our areas of means of approach when dealing with difficult patients. Now, the 3 comprised areas that I'm talking about, I break them down for you. Okay? Now, the one that I will cover with you guys right now will most likely be the emotional health. And as you read through the book, you'll also get a basic understanding what I mean when I'm talking about emotional health. So, for example, for emotional health, let's say if the patient is sad, what do you do when you're dealing with a patient that's sad and they're like, I don't want to do therapy today. I'm sad, I'm depressed, I'm down, I don't want to do anything, I'm not getting out of bed. So this is my approach. And I break it down in steps for you, and I'll show you here. I don't know if you can see that too good because I'm outside, but I just break it down for you, okay? So number 1, it says, if your patient is sad, if so, why? Okay? So you need to understand your why. So I said, first, you listen to the patient attentively. Second, you show empathy. Third, you ask the patient, what can I do to help? Fourth, you provide a solution while explaining how your services and participation in therapy is beneficial. And fifth, you keep your word and you follow through. For example, let's say Mrs. Sally is depressed because she misses home. And with her missing home, she doesn't want to get out of bed. She doesn't want to participate in therapy. So number 1, I said listen attentively. So first, you pretty much just say, hey, Mrs. Sally, how you doing? I heard that you don't want to get out of bed. You're not feeling, you feeling a little down today. What's wrong? Okay. She's most likely going to explain to you what's wrong. So you listen attentively, then you show empathy. You say, wow, I'm so sorry that you feel that way. I understand why it can be challenging. I'm sure there's no place like home, yada, 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 right? Then third, you ask the patient what you can do to help. Simple question. Just simply ask, you know what, Miss Sally, I'm so sorry that you're feeling sad and you miss home. What can I do to help you feel better? Some patients may say, you can leave me alone, and I'll give you a rebuttal for that. Or they may say, no, honey, it's okay. There's not much you can do. I'm just missing home, and I just don't feel like doing anything today. This is why the fourth step, I said, this is why you provide a solution and you explain to them the importance of participation. So I would probably say, you know what, Miss Sally, I understand. There's no place like home, and I would miss home too if I had to be here. However, you're here for a purpose and you're here for a reason. And what I can do to help you get home is by helping you get better, so you won't ever have to go to a place like this again. So the best thing we can try to do is try to do as much as you can and as much as you can tolerate, because the most important thing is you getting better so you don't have to come home. And the longer you take to do that, and the more you don't want to do your therapy, means the longer you have to stay here. And I know that's not something you want to do. So even if it means just doing a little bit today, that counts towards getting closer to going home. That tends to work. And obviously, there's more you can say, but that's just me giving you a little example. And then you keep your word. So if she says, okay, you know what, Tamisha, I'll get up and I'll do some stuff with you. And let's say during the session, she's like, you know what, Tamisha, let's say we're going through the section and she's scheduled for 60 minutes. And let's say 30 minutes later, she's like, you know what, Tamisha, I don't think there's anything else I can do. I would most likely say, okay, you know what, Mrs. Sally, why don't you rest for a little bit? Excuse me. Why don't you rest for a little bit? Because you did say, you'll let me know how much you can do and how much you can tolerate. And I would most likely allow her to rest. And I'll probably talk to her about something other than therapy, kind of take her mind off of it, and then I'll make it functional. So for example, let's say if we're in therapy and we're doing exercise and we're doing balance, and now she says, you know what, Tamisha, I think I'm done. I don't want to do anything else. And the most I say, okay, so let's head back to your room. Let's take a nice stroll back to your room. Or if she's like, you know what, I don't feel like walking, I'll probably get her to the room and say, you know what, Miss Sally, how about you sit up and we have a bite to eat, or you know what, Miss Sally, how about you show me A, B, and C. So depending on what her goals are, I can make it function. You can make it every or anything functional, just as long as you're creative and using your critical thinking skills. All right, so that was if your patient is sad. The next ones that I mentioned in the book, because this video is going to get long, is if your patient is mad, depressed, frustrated, bored. If your patient has OCD, so obsessive compulsive behavior. So I address 6 different things, guys. So the best thing I can tell you is get the book. I answer so much questions that you need or you want answered are in the book. And also I told you guys that I'm going to be providing you guys with a service where you can actually talk to me on the phone and I can answer your questions, and I can also help you out with your coursework for your schooling, so you can be an A+ student. So anyway, I'm going to cut off this vlog because it's getting real long-winded. I hope that was helpful. Please let me know if you have any other questions. I will make my videos as soon as you do through a vlog, since these are pretty fast to do. All right? See you later. Bye.